When we talk about liver function tests, the name is actually a bit misleading, as it sounds like we are checking how well the liver is working. But in reality, most of these tests are damage indicators, not performance indicators. They help us figure out what type of injury is happening and where. Think of it like warning signals rather than a full performance report. The liver plays a central role in metabolism, handling carbohydrates, proteins, and fats. So when something goes wrong, certain enzymes and metabolic byproducts leak into the blood and act as signals or biochemical markers of liver dysfunction. These include bilirubin, enzymes like ALT, AST, alkaline phosphatase, and GGT, as well as functional markers like albumin and prothrombin time. However, interpreting these tests is not always straightforward. These are non-specific tests, and we should never rely on a single parameter alone. Instead, we always interpret the full liver panel together, because sometimes only one value is abnormal or the pattern does not point to a single disease. So these tests give us an overall idea about liver injury and function, rather than a definite diagnosis on their own. Now, when we interpret liver function tests, we are not dealing with just one value, but a panel of different parameters as shown in the image. And the most practical way to make sense of them is to recognize patterns. Broadly, liver abnormalities can be grouped into three main patterns. The first is the hepatocellular pattern, where the primary issue is damage to the liver cells themselves. So enzymes like ALT and AST rise because injured hepatocytes leak these enzymes into the blood. The second is the cholestatic pattern, where the problem lies in impaired bile flow, either within the liver or in the bile ducts, leading to a more prominent rise in markers like alkaline phosphatase and GGT, often along with end changes in bilirubin levels. And in some cases, we see a mixed pattern, where features of both hepatocellular injury and cholestasis are present. Along with these injury patterns, we also assess bilirubin levels, which include total, direct, and indirect bilirubin, which help us understand bilirubin metabolism and the type of jaundice, as well as proteins like total protein, serum albumin, and globulin, and their ratio, which reflect the synthetic function of the liver. So the key to interpretation is not just reading numbers, but identifying the pattern these parameters are forming, and then using that to understand what type of liver dysfunction is present. Now, focusing on hepatocyte damage, as we discussed earlier, that it's important to understand, when we see changes in plasma enzyme levels, we are actually detecting liver cell membrane injury, not directly measuring how well the liver is functioning. These enzymes leak into the blood when the cell membranes are damaged. Also remember, these enzymes are not exclusive to the liver. They are present in other tissues as well. So a rise in their levels can sometimes reflect injury outside the liver, which is an important limitation. Among these enzymes, the most important are the aminotransferases, Alanine Aminotransferase or ALT and Aspartate Aminotransferase or AST. These enzymes normally work inside cells, helping in metabolism, specifically in processes like gluconeogenesis. An increase in their levels is a very sensitive indicator of damage to either the cytoplasmic membrane or even the mitochondrial membrane of hepatocytes. And even injury to a small number of cells can cause a noticeable rise. Now, although liver cells actually contain more AST than ALT, ALT is confined mainly to the cytoplasm and is present there in higher concentration compared to AST, which is found in both cytoplasm and mitochondria, but a significant proportion is located in the mitochondria. So when we see raised transaminase levels, it tells us that hepatocyte injury has occurred, but it does not tell us the exact cause or mechanism. However, the pattern of rise can give us clues. For example, in inflammatory or infective conditions like viral hepatitis, the main damage is to the cytoplasmic membrane. So there is a relatively greater increase in ALT compared to AST because ALT is present in cytoplasm. On the other hand, in infiltrative or more severe disorders where both mitochondrial and cytoplasmic membranes are damaged, AST tends to rise more than ALT. This is why comparing the two becomes clinically useful. In most liver diseases, especially conditions like viral hepatitis, ALT tends to be higher than AST. This is not simply because ALT is more concentrated, but because ALT is located mainly in the cytoplasm, and early or mild hepatocyte injury primarily damages the cytoplasmic membrane. As a result, ALT leaks out more readily into the blood. The ALT is more specific to the liver because it is mainly found in liver cells. So when ALT is elevated, we think more directly of liver injury. In contrast, AST is present in many other tissues like muscle, heart, and even red blood cells. So it can rise in non-liver conditions as well, making it less specific. In day-to-day clinical practice, mild abnormalities in liver tests are actually quite common. Around 8% of people may show elevated values, and importantly, many of these are temporary, with up to 1/3 returning to normal within a few weeks. So not every abnormal report means serious disease. That's why we should avoid overreacting to a single borderline value. Now, let's look at each of these enzymes individually, starting with ALT. The normal serum range of ALT is about 7 to 56 units per liter. Any type of liver cell injury can lead to a rise in ALT levels, but mild to moderate elevations, up to around 300 units per liter, are often non-specific. When ALT levels rise markedly, especially above 500 units per liter, this usually points toward conditions that primarily affect hepatocytes, such as viral hepatitis, ischemic liver injury, and toxin-induced liver damage. Viral hepatitis, types A, B, C, D, and E, can all cause significant increases in ALT. And interestingly, hepatitis C tends to cause a greater rise compared to hepatitis A or B. In cases of acute hepatitis C, ALT levels are often monitored periodically for 1 to 2 years. And if ALT remains elevated for more than 6 months after an acute episode, it supports the diagnosis of chronic hepatitis. ALT levels are also higher in non-alcoholic steatohepatitis and in conditions like childhood obesity and non-alcoholic fatty liver disease. Hepatic fat accumulation causes injury to liver cells, leading to an increase in ALT levels. Physiologically, ALT can also be elevated during the second trimester of a normal pregnancy. In symptomatic pregnancy-related conditions such as hyperemesis gravidarum, preeclampsia, and HELP syndrome, ALT levels can rise significantly but typically fall rapidly, often by more than 50% within 3 days after delivery, indicating recovery. Finally, an interesting protective factor is that coffee and caffeine consumption have been shown to reduce the risk of elevated ALT levels in individuals with risk factors such as excessive alcohol use, viral hepatitis, iron overload, obesity, and impaired glucose metabolism. Now moving on to AST. The normal serum AST level typically ranges from 10 to 35 units per liter. AST is present not only in the liver but also in other tissues, which is why it is less specific for liver disease compared to ALT. It exists in two genetically distinct isoenzyme forms, a cytoplasmic form and a mitochondrial form. Now clinically, the mitochondrial form of AST becomes particularly important because it is released in conditions involving more severe or extensive tissue damage, such as myocardial infarction and chronic liver diseases associated with liver cell degeneration and necrosis, where disease process damages the mitochondria. So when AST is disproportionately higher than ALT, it indirectly suggests more severe hepatocellular injury with mitochondrial damage. So it is important to note that in early liver disease, ALT is usually higher than AST. But as the disease becomes chronic or progresses to cirrhosis, AST often becomes higher than ALT due to more severe and mitochondrial damage. So AST may become more prominent as the disease progresses. Similar to ALT, AST can also be elevated in pregnancy-related conditions such as hyperemesis gravidarum, preeclampsia, and HELP syndrome, usually showing mild to moderate elevations which tend to improve after delivery. So overall, while AST is a useful marker of hepatocellular injury, its interpretation always requires caution because of its presence in multiple tissues. Now the AST to ALT ratio can provide important diagnostic hints. Since AST is associated with more severe or advanced liver injury than ALT, an increase in the AST to ALT ratio may suggest more severe liver disease. So clinically, this ratio tends to increase as liver disease progresses, and a higher AST to ALT ratio can suggest the presence of cirrhosis. In different disease states, the AST to ALT ratio follows characteristic patterns. For example, it is around 1.3 in post-necrotic cirrhosis. However, one of the most important and classic findings is that an AST to ALT ratio greater than 2 is strongly suggestive of alcoholic hepatitis. This ratio can also help differentiate conditions. For instance, it is typically around 0.9 in non-alcoholic steatohepatitis compared to about 2.6 in alcoholic liver disease. In some less common conditions, the ratio can be even higher. For example, it may exceed 4.5 in Wilson's disease, and similar elevations can also be seen in hyperthyroidism. So overall, the AST to ALT ratio is a valuable tool. Now moving on to cholestatic parameters, one of the most important markers is alkaline phosphatase. It is a zinc-dependent enzyme that is highly concentrated in the microvilli of the bile canaliculi in the liver. So any injury to the bile canaliculi can lead to an increase in ALP levels. But this enzyme is also present in other tissues, including small intestine, the PCT of the kidney, bone, and placenta. In the blood, serum ALP mainly originates from the liver, although about 50% of its activity is contributed by bone. The normal serum ALP range is roughly 41 to 133 units per liter. In most cases of acute viral hepatitis, ALP remains normal or only mildly elevated. However, if cholestasis develops, meaning bile flow is impaired, such as in hepatitis A, patients may present with symptoms like prolonged itching, and in such cases, ALP levels rise more significantly. So conditions associated with impaired bile flow or cholestasis, either direct or indirect, commonly lead to a rise in ALP levels. This includes infiltrative liver diseases, liver abscesses, TB and amyloidosis, which cause intrahepatic cholestasis. In contrast, milder elevations in ALP may be seen in conditions like cirrhosis, and hepatitis, and also in congestive cardiac failure when there is associated hepatic congestion. On the other hand, low ALP levels are less common, but can occur in conditions like hypothyroidism, pernicious anemia, zinc deficiency, and congenital hypophosphatasia. Physiologically, ALP levels increase during the third trimester of normal pregnancy due to placental production. Clinically, one of the common challenges is differentiating whether a raised ALP is coming from the liver or bone, and in such cases, measuring gamma-glutamyl transferase becomes very useful. Gamma-glutamyl transferase, or GGT, this is another important cholestatic marker. GGT is a microsomal enzyme present in hepatocytes and biliary epithelial cells, but it is also found in other tissues such as renal tubules, pancreas, and intestine. It is considered more specific for biliary disease when compared to alkaline phosphatase because, importantly, it is not present in bone. Clinically, GGT is quite sensitive in obstructive liver disease, where its levels can rise significantly, on average up to about 12-fold, whereas ALP may increase only around 3-fold, making GGT a slightly more sensitive marker in this context. So, if ALP is elevated along with GGT, the most likely source is hepatobiliary disease, particularly involving the biliary system. Whereas, if ALP is elevated with a normal GGT, the source is more likely non-hepatic, such as bone. It is synthesized and processed within the smooth endoplasmic reticulum of hepatobiliary tract before it is transported to its final location on the cell surface membrane. As this reticulum proliferates, for example in response to the prolonged intake of alcohol and also because of drugs such as phenobarbital and phenytoin, as a result, synthesis of the enzyme is also induced and plasma GGT activity increases. Therefore, raised plasma activities do not necessarily indicate hepatocellular damage, but may reflect enzyme induction. The normal serum level ranges from about 9 to 85 units per liter. In acute viral hepatitis, GGT levels typically peak during the second or third week of illness and may remain elevated for up to 6 weeks in some patients. An infant with biliary atresia has obstruction or absence of the bile ducts, which leads to impaired bile flow or cholestasis. And because GGT is produced by biliary epithelial cells, this results in a marked rise in GGT levels. When the infant undergoes surgical treatment and bile flow improves, GGT levels usually start to decrease, reflecting recovery. However, if the infant is breastfed, GGT levels may remain elevated despite clinical improvement because human breast milk contains significant amounts of GGT which can be absorbed and contribute to higher measured serum levels during the early weeks after birth. Plasma GGT levels tend to increase with body weight and can be about 50% higher in individuals with a BMI above 30, mainly due to fat deposition in the liver or steatosis. This pattern is also seen in conditions like diabetes mellitus, non-alcoholic steatohepatitis, and non-alcoholic fatty liver disease, where fat accumulation in the liver can injure hepatocytes and also impair bile flow in the hepatobiliary system, leading to elevated GGT levels. So we can understand that any condition that damages the hepatobiliary system, whether it is chronic liver disease, obstruction, infiltration, or infection, can lead to a rise in both GGT and ALP. This includes conditions like alcoholic cirrhosis, primary biliary cholangitis, malignancies such as carcinoma or metastasis, and infections like tuberculosis. One of the most striking elevations is seen in alcoholism, where GGT levels can rise to more than 10 times the normal value, partly due to structural liver damage, induction of hepatic microsomal enzymes, and even alcoholic pancreatic injury. Now, another enzyme to know is 5' nucleotidase. It is present on the bile canalicular and sinusoidal membranes of liver cells, although its exact function is not very clear. Clinically, it works similar to GGT. Its main use is to identify the source of an elevated alkaline phosphatase. If 5' nucleotidase is also elevated along with ALP, it suggests a hepatobiliary cause, whereas if it is normal, the elevation in ALP is more likely from bone. So when ALP is elevated along with GGT, it strongly points toward a hepatobiliary source, whereas a normal GGT with raised ALP suggests a non-hepatic cause like bone. Similarly, 5' nucleotidase serves a comparable role in confirming the hepatic origin of ALP elevation. So overall, GGT is best used as a supportive marker that helps localize the source of abnormal liver tests, rather than providing a definitive diagnosis on its own. Now coming to bilirubin, we have covered its metabolism and interpretation in detail in a separate video. In that video, we clearly explain how total, direct, and indirect bilirubin levels change in different conditions, along with associated changes in stool and urine color. I would strongly recommend you to watch that video for a better understanding. Now, the synthetic function of the liver, the two main tests we rely on are serum albumin and prothrombin time. This is where we assess how well the liver is actually performing its job, not just whether it is injured. One of the key markers here is albumin, which is produced by liver cells. Its production depends on factors like dietary protein intake and oncotic pressure, and it is also regulated by the existing albumin level in the blood. That is, when the albumin level in the blood is low, the liver increases its production, and when the level is adequate, production is reduced. Albumin has a long half-life of about 21 days. Because of this, even if the liver suddenly stops producing albumin, for example, in an acute liver injury, the already circulating albumin will still remain in the blood for days to weeks, so the level does not fall immediately. That's why albumin is not a good marker for acute liver damage. Instead, a low albumin level usually indicates a long-standing or chronic problem. Albumin is widely distributed in body fluids, is minimally lost through excretion, and is broken down in various tissues, with its amino acids being recycled. In liver disease, serum albumin levels usually fall due to reduced synthesis. However, if albumin is low but liver function is otherwise normal, we should think of other causes like poor nutrition, nephrotic syndrome, malabsorption, or protein-losing enteropathy. So hypoalbuminemia is not very specific for liver dysfunction alone. However, if albumin is low, it may suggest that the liver disease is chronic in nature. Another important test is prothrombin time, which measures how quickly blood can clot. PT can be prolonged for two main reasons. First, in conditions like cholestasis, where bile flow is impaired. Bile salts do not reach the intestine properly, and as a result, fat absorption is affected. Since vitamin K is a fat-soluble vitamin, it cannot be absorbed adequately, leading to a deficiency. This causes a prolongation of prothrombin time. But importantly, in this situation, if we give vitamin K by injection, the prothrombin time will correct, because the liver is still capable of synthesizing clotting factors. On the other hand, in severe liver disease, where there is significant loss of functioning liver cells, the liver cannot produce clotting factors, even if vitamin K is available, as most clotting factors, except factor VIII, are produced in the liver. So in such cases, prothrombin time remains prolonged and does not correct with vitamin K administration. So this simple distinction, whether PT corrects with vitamin K or not, helps us differentiate between a problem of vitamin K deficiency due to cholestasis and true impairment of liver synthetic function. Additionally, if PT is prolonged in the presence of otherwise normal liver function, other causes such as warfarin therapy or disseminated intravascular coagulation should be considered. So together, albumin and PT give us a clearer idea of the liver's true functional capacity. Now, another important component of the liver panel is globulin and the albumin to globulin ratio. Albumin, as we discussed, is synthesized by the liver, whereas globulins are produced by both the liver and the immune system, but mainly by the immune system. In chronic liver disease, two things happen simultaneously. First, the damaged liver is unable to synthesize enough albumin, so albumin levels fall. And second, there is persistent inflammation and immune activation, which leads to increased production of globulins, along with reduced clearance by the liver. Because of this opposite change, albumin decreasing and globulin increasing, the albumin to globulin ratio, which is normally more than 1, becomes reversed and falls below 1. This reversal of the albumin to globulin ratio is an important clue that suggests chronicity of liver disease, particularly in conditions like cirrhosis and chronic hepatitis, rather than acute liver injury.